This is the Neurosurgery Podcast. Welcome back to the Neurosurgery Podcast. Today, I am truly honored and delighted to have a guest on the show that maybe might not be familiar to some of our mainly neurosurgical audience, but anyone with an MD after their name or who is planning to have those letters after their name, or DO, or any associated specialties should know the name Adam Cifu. Dr. Cifu is a partner in crime of former guest on the show and now federal employee Vinay Prasad. And in addition to his day job, where he's a professor of medicine at the University of Chicago and a titan of medical education, he writes for Sensible Medicine, which is a fantastic online source. We'll link to that, looking at all different aspects of medical education, medical research, and public policy. But Dr. Cifu, for again the knuckle-dragging surgeons who don't think so highly within the broad field of medicine, please take a moment and say hello and introduce yourself to our audience.
Thanks so much for having me on, and that's maybe the nicest introduction I've ever had. I probably don't deserve that, but I appreciate it, and I appreciate talking to people a little bit outside my usual sphere. Though I do talk to the neurosurgeons here at the University of Chicago. They're a great crowd and wonderful colleagues, so happy to be here.
Yes, well, I'll try to rein myself in. I'm gushing because I genuinely am a fan. And God bless this podcast. We've been going on 7 years now, and the opportunities it's given me to meet people within neurosurgery and now outside of neurosurgery whose writing I just adore. Thank you for everyone who's stayed on board with the show for so long to enable this. So, Dr. Cifu, the topic today is going to be evidence.
Okay.
Evidence in medicine, evidence for medicine, evidence-based medicine. Neurosurgeons always joke that there's no evidence for anything that we do. And maybe 20, 30 years ago, that was more true.
Yeah.
We've gotten a little better these days. We have some trials that we can hang our hats on. But
Yeah.
before we dive into the details of it and we get into some neurosurgical case studies, for example, why don't you talk very broadly on your mental map of what is evidence to a doctor versus just a pure scientist? How do we approach that question?
Yeah, it's a great question. And it's one of those questions that, although I've been thinking about it for probably 20 years now, I still don't have a great answer, right? I think most of us in our training, we sort of get a sense of what works both diagnostically and therapeutically because we learn anatomy, we learn pathophysiology, we're human beings, so we can tell good stories. And we're sort of like, okay, this should work. And my patient either is the same or better after I do this. And so I'm confident in that. Um, I think we've learned over, I don't know, the last 30 years during the sort of heyday of evidence-based medicine that a lot of things that we think should work based on our science actually don't work. We've actually learned that a lot of the things that we think work because we do them in clinic and people seem like they get better because of it. Those also don't work. People get better because the human body is amazing and they get better, or because we're, thoughtful doctors and the patients feel better because they've been cared for. But nothing we do has actually done anything except, charge their insurance or Medicare or whatever. And there are some fields that it's been pretty easy. I mean, easy. I'm saying that as like a non-researcher, definitely in quotations, to do large randomized controlled trials to actually show that something has a robust impact on, the majority of people we take care of, or at least a small significant minority. There are other fields where it's much more difficult to get that sort of high level evidence. You guys are coming from one of those fields because, um, the interventions you do, it's hard to randomize a large number of people to one intervention versus another intervention. Though I do think, just to finish up, I think surgery in general is a place that we can do a whole lot better in figuring out what works. And those studies probably shouldn't look like cardiology trials where we randomize 4,000 people to a statin, 4,000 people not to. But there should probably be efforts at at little tiny advances in what you guys do in the operating room, in decisions that you make every day, almost without thinking about them.
Dr. Cifu, fantastic. I love where you're going with this, and it's so balanced. And by the way, congratulations, Mo Biden, the new department chair at University of Chicago, right?
Yes.
Shout out to Mo. Yeah, he's been on the show before, and we love him.
Good.
And he is into this. He is into the big databases and using, big data analytics, and of course now AI. But can you help me with the part that patients intersect with? So, patient comes to see us, right?
Right.
And what they look for, if science is the evidence-based medicine, right? But the reality is the patient only cares about themselves, right?
Yes.
They just care about what's going to happen to them. Is it true that evidence-based medicine is just about large populations and statistics, or is evidence-based medicine actually something bigger than that? Because I feel like people sometimes conflate the two.
Right. So I think what evidence based medicine does, and I'm going to bring it to, let's say, my sphere of practice. Okay. So if someone comes into me with diabetes and they've got a hemoglobin A1C of 8, not horribly controlled diabetes, not diabetes that's given them daily symptoms, but diabetes that's less controlled than I would like. And I argue that that person, we should add a drug to your regimen to get your sugar down. And they say, why? And my response is generally, well, because when we look at populations, we know that people with an A1C of 7 do better than with an A1C of 8. Um, and if the patient is, I don't know, a little bit edgy and prickly, they will say, well, sure, that's fine for population, but is that true for me? Um, my answer is generally, well, I don't know. But, I can tell that it probably gives you a better chance of doing well than not, but you have to make that decision, right? You have to decide that if that benefit, and sometimes I can give them a percentage, is worth, taking a pill every day, taking a shot every day, having the side effects of the medication. And, we're all into sort of shared decision making these days. And so we're comfortable with that. I think, and certainly, you guys are not going to let me speak for you. Um, what's hard is that generally, the decision a patient makes for you is I'm going to operate or I'm not going to operate. Um, but then a lot of the decisions that you make when you're actually doing your job, the patient's not involved in those decisions, right? It's, do I do this fusion? Do I put a screw here or here? Um, and those are the decisions that are completely yours that should be driven by data, but I think often are more driven by sort of anatomy, pathophysiology, and uncontrolled experience.
Yeah, one of my current bosses and mentors, Ricardo Fontes, he does complex spinal deformity. He all of our consents for spine surgeries always say possible additional levels, right?
Yeah,
Because there's the game day
right.
decisions, and I've heard him say to hundreds of patients at this point over the years, what you're really doing here is an act of trust. Like,
Yeah,
yes, I'm telling you what we're planning to do, but what you're really saying is, I trust you and you're trusting us to do our best job and whatever happens be there and take care of it for you. But all of those things that happen once the patient, as you say, is not awake for us, can't
yeah,
possibly contribute to it. It's an act of trust that we know their interests and we will enact them as best that we can. Thinking about the patients and trying to bring it back to somewhere that we share in life, the clinic, we often deal with the patients who come in who have done their homework. And we used to talk about talking to Dr. Google. Now maybe it's Dr. Grok or Dr. GPT or what have you. And they come in and they've brought their own evidence for what they think, right? And we always joke about the Dr. Google and the patients who do their homework. And now we have to address that. But the question I want to put to you is slightly more complex because we as the physicians have that problem as well. We have a glut of information. And because of the internet and the information age and the electronic distribution of information, it's so easy to, and I'm using scare quotes again for anyone
yeah,
just listening, it's so easy to publish things.
right.
And so, whereas maybe when I was a kid and coming into high school and college, if something was published, the idea was it's pretty reliable because there were gatekeepers. Now you can publish anything somewhere. There's a home for every paper. There are journals that have explicit, everyone knows it, political motivations. And so we see these papers where somebody got something published and now it's in published literature. Or we know there's the bottom drawer effect, where some things that may be true, the question is never asked or the paper is never sent in because of what they found. So when we talk about evidence-based medicine, there's a lot of information, and then there's things that we should treat as evidence. How do you find that line to walk between what is just someone saying it out loud or typing it and what is true, reliable evidence?
Right. So I think there are two great points in that I want to respond to. One is I've been a little bit of a fanatic in my writing these days, advocating for something which will not happen, but we need to get rid of about 80% of our journals, because the medical literature is just filled with garbage these days, um, and it's mostly the neurosurgery residency's fault, right? Because you can't even apply to neurosurgery unless you have 25 papers. And all those 25 papers are garbage and they're not moving the field ahead, right? So you're the problem, damn it.
Give us back step one.
Right. Well, I think they should bring back step one. We should test students on the things that they need to know to at least suggest that they're going to do well in clinical practice. And
Right.
that's not being 15th author on like another case series that's a waste of time. But getting off that high horse,
Yeah.
I think one thing that this does make my brand of evidence-based medicine important is that, one, as physicians, we really have to get good at reading the medical literature, and it's not that complex. A lot of people say, "Oh, to read the medical literature these days, with how involved pharma is in making their studies look good, you have to have an MPH at very least, and maybe a PhD." I don't think that's true. I think it's mostly saying, does this study address a clinical question that's important? And are there clear ways that, the design has been fiddled with, to get the answer that, probably this drug or device company wanted to get? And so I think we can do that well. Interestingly, the other sort of answer to your question, I think, is that although I'm a believer in that things work because they've been shown in robust trials to work, and not because they should work or we want them to work or because we make money off of doing them. Um, it's important now that we actually kind of go back to our knowledge, right? Um, because when there's so much information out there and there's so many guidelines out there, it's becoming more important to personalize care with a patient you're sitting in front of, because that's the difference between us and an AI chatbot that's, for the most part, taking like, the general gestalt of how to interpret the knowledge from the internet and giving that to a patient. Where we sit is, okay, look, you've been on this medication, this medication, this medication. From your history, I think this is sort of the version of asthma that you have. Or for you guys, I know who's been in your back before. I know what's been done. And why evidence-based medicine is so tough for you is that, on a patient who's already been through surgery before, that is truly a unique person, right? And so it takes sort of weighing what I know from the literature with what I know from both experience and, um, the kind of biomechanics, I guess. And that's how evidence-based medicine was initially defined. It's not following what's the last article was in the New England Journal, but it's integrating medical knowledge, experience, and the best available data from the medical literature.
Yeah, amen to that. I will be convinced of AI's utility when it tells the patient you need to lose weight, you
Right.
need to quit smoking, right?
And
But to
anybody
back,
can be sued, right?
yeah, right. Back to your, you get 1 star.
Yeah.
Back to your high horse. We actually had an applicant a couple years ago from Chicago, not from University of Chicago, who had 182 peer-reviewed papers coming in. Yeah, but I want to ask a question
Years
that,
like that, who needs enemies?
yeah, right. We can argue how important the papers were, the H index and all that, but it was 182. Um, hundreds of hours of recording JP and I have done, but I've never asked this question. I've wanted to ask this question. I have my bias. So I want to ask you, because you're an expert on this. Is there such thing as a placebo effect from surgery?
Absolutely, definitively, yes. um, and I think where we've seen that, well, let me go back to 2009 with maybe my favorite article. Maybe it's a procedure rather than a surgery, but you guys would know it well. The two vertebroplasty articles that were in the New England Journal. Certainly, I know things have changed a lot since then, but what that showed is that at the time, a lot of people who were having vertebroplasty were getting better, not because of what was done to their spine, but because they were being taken to the operating room, they were being cared for, they were smelling the medical cement, and they came out of it saying, "Oh boy, I feel better." When in fact, a month afterwards, they were the same with placebo. One of my favorite examples that I frequently use is going all the way back to the 1950s. Um, when an Italian surgery was doing intrathoracic artery ligation for angina, with the idea that if we tied off the internal thoracic mammary arteries, as they were called, would sort of cause a backup of pressure and give better perfusion to the coronary arteries. And people had no doubt that they came out of that procedure with less angina. Like there was no question. And this guy was making a fortune. And then finally, there was a terrific sham surgery study where people either had internal mammary artery ligation, or they had two nice little incisions placed on the upper portion of their chest. They were then sewed up. And lo and behold, those two groups of patients did identically. So, absolutely, placebos work in surgery. And it's what makes it even more difficult because if you're trying to do a good RCT of a surgical procedure, you really need a sham procedure. And that just brings things to a higher level of complexity as far as getting it through IRB, getting patients to consent, and actually doing the procedure.
Yeah, so I want to pivot a little bit now because if I brought you on to talk about evidence-based medicine. So we've talked a lot about evidence now. I mean, all three of us are pretty based. I'll go ahead and say it. So then the remaining question is, what do we even call medicine, right? And so one of the other topics I've interacted with you online about is this concept that I certainly didn't come up with the concept. I don't think I even coined the phrase, but it's one of my mantras in the past couple of years is the medicalization of everyday life.
Yeah,
And it's just the stuff that we call healthcare or wellness related or medicine has been expanding dramatically as hand in hand the percentage of the American economy that's
yeah,
taken up by healthcare expands dramatically. Such a shocking correlation there. But as that happens, the duties, responsibilities, or more realistically, expectations of doctors continues to expand. While lo and behold, we also have a doctor shortage, and so
sure.
I wonder if you could talk a bit about, because you wrote a phenomenal article on your Substack a few months ago about this that kind of prompted me reaching out to you and have you on the show. I wonder if you could talk a little bit about this. You could even call it a scope creep,
Yeah.
where more and more parts of what used to just be everyday life are now considered healthcare, and the increasing demands that puts on our healthcare workforce while there are apparently not enough of us.
Yeah. I'm so glad you brought this up. I've actually been working on another article about this, um, and where it is in my practice, which I think will have sort of a nice corollary to where I'm sure it is in your practice, is that I've been in the same practice now since 1997. Okay, so
Wow.
the majority of my patients are over 70 years old. Many of my patients are above 80. Um, and many of the things that I see people for are sort of part of the human condition, right?
Yeah.
Um, things just don't work as well as you get older. It may be aches and pains, it might be energy, it might even be cognition. Um, and people ask me about them. And it's very difficult in today's world to be like, I'm here to care for you and I will care for you. But that's normal. And I can help you deal with it a little bit more, but I am going to work to not medicalize it. I'm going to work to not evaluate it more than me thinking about it. I'm going to work to not refer you to other people, because that's just sort of something that we have to live with. Um, Part of that is back pain, right? Um, I mean, there are very few people who I see, even if they can like get on the floor and do a plank for, 45 minutes, not that my visits are that long, they've done everything well, but occasionally they're still like, I'm a little bit achy this morning or whatever. That's normal. Um, but I think because there are a lot of people making money, as you suggest, by medicalizing all of this stuff, and whether it's screening procedures, whether it's things that are going to, supposedly prevent illnesses down the line, or whether it's just treating things which don't need to be treated, we're up against this every day, and our patients bring it to us because they've been sort of schooled by the internet, the media, by sort of snake oil salesmen, right, who can make money. And so they're asking us to make everything better.
What do you think of direct to patient pharmaceutical ads?
Uh, you know, on the one hand, the easy answer is, oh my God, they're terrible. And the only countries who allow them is, America and New Zealand, right? Um, but they do educate patients to some extent, right? And I do believe that there are people who end up in the doctor's office with treatable conditions because of advertising. Um, what I wish, and I know there are people working on this, is that there should be places that people can go to get information about drugs that are not just pharma ads. Um, but that really doesn't exist in a great way, right? Where people can say,
Yeah.
I'm interested in the latest TNF inhibitor. Um, what is the data on this?
Well,
What's
I would be okay with it if they actually had information. Like, all I see is people having a picnic. I don't even know. Like, the quality is what bothers me. I don't want to watch the ad, not because I mean I'd be interested if they talk about mechanism of action, price,
I know.
dosing, anything other than like someone having a picnic or something. I don't like.
And absolute risk reduction and number needed to treat, right? I mean, those are the things that people know. But the people on the ads, they're all very happy and they all have very nice skin. So I'm
I
happy
want to
to.
see some sick, depressed people. But so let's segue a little bit over that because I know you're an expert in this. So tell us a little about. I mean, we're just talking the abstract,
Yeah,
right? In Ivory Tower. What about the policy, payer, social economic implications of all of this? Because that's really where the rubber meets the road, right?
that is. And people talk again and again about one of our problems is that people don't have skin in the game. And you know, I certainly don't have an answer to this. And um, but so often I have patients who come in and ask me for things, um, which I know there's nothing I can do about this, right? And I really think I've been doing this long enough that if I have the time, I can counsel the patient through their problems and what they can do about it for themselves and how they can adjust to the fact that this is sort of part of life. Um, or I can give them something. And usually if I told the patient, here, this is an option, I don't really think it's going to work and it'll cost you $100, most patients at that point I think would accept the fact that, okay, well, I'm just going to live with this. But because these things are paid for, most patients will say, okay, I'll give it a try. That $100 will be another $100, which goes into the kind of, or comes out of the government coffers or insurance coffers, which we all eventually pay for, um, which is a problem. Now, obviously, once we start having people pay for things, problems with healthcare disparities go through the roof. That people pay for, some people will pay for things, other people won't pay for things. Maybe the poor people suffer, and so there needs to be really imaginative and brave limitations put on what we do and do not pay for. But I think if we don't want healthcare to be, 90% of our GDP instead of whatever 18% that it is now, we really need to start making those decisions.
Yeah, we've talked a lot in previous conversations on the show and elsewhere about the runaway spending in healthcare, both by patients and physicians, because as you say, it's all funny money, and I think north of 80 or 85% of neurosurgeons now in the country are employed, and so we're playing with house money.
Yeah.
The patients, their insurance is now a Netflix subscription to the healthcare industry, so they're even though it is coming out of their paychecks, they're not handing over the cash. And we know from psychology literature that if you're not making the payment yourself, even if it's coming out of your own account, you don't feel it, and so you're not as inhibited. You spend more freely and you say yes to those possibly frivolous things that the doctor is offering you out of the goodness of our hearts, right?
And
um,
we've trained people so well, poorly, that it's going to be really hard to wind things back. Um, because I certainly have people who get to the pharmacy to buy something which is, I don't know, generally unimportant. Okay, a cream for a rash. My wife's a dermatologist, so I'm not disrespecting dermatology. I promise you. Um, but I get a call saying, I went and it cost $20. What the hell? I'm not paying that.
right.
Um, and my response is often, how much did you pay for coffee the last 2 days?
Right.
If this is something important for your health. But that said, I do understand that, right? We're used to this being free, and it's hard to get people to change.
Well, speaking of medicalizing everyday life and over intervening or over testing, it would be remiss to have you on the program and not talk about another bee in your bonnet and mine, screening. And for neurosurgeons, most of the time, neurosurgeons don't really interact with screening medicine. Most of us since medical school, except of course in the emergency room in the trauma bay, where CT scans from head to tail are treated as screening
Right,
medicine, of
right,
course, the
right.
pan scan. But now, as technology continues to advance and concierge and boutique medicine continues to advance, we're seeing all these wonderful whole body MRIs that people can get done for cash out of pocket. And of course, there's now the controversy about, does a radiologist read it? Will AI read it? Who's responsible for missing every tiny incidentaloma and what could come of that? So maybe sound off with your opinion on the concept of screening medicine and then how we actually do it in this country and where we may do it well and where we may do it poorly.
So I guess maybe I'll define, what would make a good screening test, right? A screening test should, the definition is it should pick up preclinical disease, okay? And it should change an important outcome above and beyond waiting for that disease to become clinically apparent, okay? And so that demands that there's a preclinical stage. It demands that we have treatment that's better in the preclinical stage than in the clinical stage. And it demands not that the outcome is that we allow people to live longer with the disease, which is lead time bias, but we actually improve an important outcome. People die less frequently. People's quality of life is improved. And we can argue about what the mortality endpoint we're looking at. Is it breast cancer specific mortality or is it overall mortality? Those are, I think, hard questions and important questions. But the fact is, a lot of the screening tests that we're beginning to see now, whether it's blood tests for cell free DNA, whether it's MRIs,
Mm.
are really based on, sort of a prayer. The idea that, well, maybe if we find something, that'll be good. Um, Ignoring all the harm, and the harm is um, early diagnosis of things that don't need to be diagnosed early. So you're letting people live with a disease for longer, which isn't helping at all. Overdiagnosis, picking up things which don't need to be diagnosed, but then although the person paid $1,000 for their MRI, all of us end up paying for the removal of an unimportant tumor or the biopsy of a bone island in their spine, which would have been better left alone. Um, um, and then it is um, I guess I'll leave it at that. So what I hope is that there is demand from who from payers it's going to have to be, to say, listen, we are not going to pay for the downstream workup of these tests until you show us that these tests are beneficial. And I think what would probably happen if that's the case is there'll be some things found on MRI that actually rarely need to be taken care of. But most of the things that we're find are going to be incidentalomas, which will just run up costs and anxieties among our patients.
Yeah, it drives me up the wall because we deal with the medicalization of everyday life, and this over screening, over testing is the medicalization of everyday people. And it just turns people into patients and gets them in the pipeline, and then many of them never escape. Um,
I have to say, though, I am thrilled with this because I think it's going to make the neurosurgeons who make more money than me deal with things like all the abnormal MRI findings in their spines. And, it's just, I don't know, it's fairness finally coming around.
oh my goodness, you've got a killer soundbite every 2 minutes. This is phenomenal. Well, I know we need to respect your time tonight, and we're going to wrap up shortly. But before we do, another podcast that I love, Trigonometry, they always close their episodes with the same question: what's the one thing we're not talking about that we should? And so I'd like to put that question to you in the context of the evolving medical landscape in 2026 now in our country. And I'll give you the option to answer it two ways: either just in general, for everyone in healthcare, patient to physician, what are we not talking about that we should? Or since you have a semi unique audience, you're talking to a community largely of neurosurgeons and spine surgeons, it's a very focused audience that we have. So if you'd like to tailor it to what are surgeons and neurosurgeons and spine surgeons not talking about that you think we should, however you'd like to take it.
Yeah. I think maybe after disrespecting you guys, I'll sort of circle back and I'll say something complimentary, which is, I think, important for all of medicine. Because we have so much technology and the ability to do so much these days, I think there's probably more of a challenge to all of us to sort of, aim high in steering, right? To think into the future about, why am I doing this test? Why am I doing this procedure? How much am I going to help the patient down the line? Rather than, it's basically the what should I do rather than what can I do? Um, I have to say that the spine surgeons I work with are maybe the most thoughtful about that question of any doctors I work with, and truly, um, any of the internal medicine doctors I work with. I think because the tests that we can order, the treatments we can order, often really don't do a whole lot of harm. I think the spine surgeons are so clear that, man, we can really create problems once we get in there. And there's a lot of suffering, which truly, like, once you've been doing this, once you guys do this for a while, know that you can't help. Um, and so I just have so much appreciation to the spine surgeons I work with who will say, I can't help you with this. This is not a surgical problem. I'm sorry you're suffering with this. I will still care for you and I will recommend non-surgical, means of trying to help your problem. Um, but this is not a surgical issue. And I think probably a lot of medicine can learn from that and learn that maybe even though it's, a Z-Pack rather than a laminectomy, um, you can still say, no, this is the wrong thing. And we're better off sort of watching and waiting.
What a beautiful message to close on. Reject intervention bias, embrace humility, and have the courage to care for people, even if that doesn't come in the form of doing something to their bodies, if I may be so bold as to
Oh,
summarize.
so well
Uh,
said.
Dr. Cifu, I'm going to restrain myself from gushing again. Truly an honor and very grateful for your time to come on the show. I hope we can have you back again sometime in the near future. This has been a phenomenal and far reaching conversation on behalf of all of our audience who, again, are primarily surgeons and may not be exposed to your way of thinking. Thank you for sharing this perspective. Thank you very much, sir, for coming on the Neurosurgery podcast.
I would love to be back, and I will promise you that when we cover neurosurgery articles on sensible medicine, which is rare, but I will tag you guys because I would love to talk to some people who know more about them than I do.
Beautiful. Look forward to it.